You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Cash, thanks so much for joining us.
No problem.
So, as a respiratory therapist, share with us your expertise. What is it like to care for patients that are awake on the ventilator?
Well, if they are awake and they are not delirious, it's actually not too bad to work with them. For the most part, here at the hospital we work at here, we most of the time do not sedate them, other than maybe for the procedure of doing the intubation, and then 10-15 minutes later then they wake up. And
what is it like when they wake up at first?
They'll definitely be uncomfortable, as you would imagine, having a tube down your throat, but they might have some coughing spells, some little bit of gagging for a few minutes, trying to get used to it, especially if they're on assist control, uncomfortable at first, and blowing CPAP pressures that they're trying to breathe against.
Mm-hmm.
It takes them a minute to get used to it. But if they aren't totally drugged out of their minds, then they can usually kind of use their brain to adjust themselves, and they actually get comfortable fairly quickly, I would say. Within 15 minutes or so, they're usually saying, okay.
Are they trying to pull the tube out after that?
Most of the time we don't see them trying to reach for it. There's the occasional patient that you have to keep their hands tied down, but usually we keep their hands tied down for the first little while. Then they kind of come to terms with their situation. And if their behavior is well enough, we actually many a time untie their hands and let them be. And rarely have we ever had a problem with that. I can recall of once, and she was kind of terminal, and I think she was just done with it in general.
Intentionally, yes.
Yeah. She was done.
But most people are able to scratch their noses, suction their mouths.
Yeah, so they take part in their own care. I just hand them the Yonkar, and they can clean out their mouths as they wish and not have to drool on themselves.
Isn't that great? That's what I would want. I wouldn't want to lay there feeling drool running down my face and not be able to do anything about it. I didn't think about that. Yeah, I think that's a part of keeping them dignified and having control of their situation. That's a really good point. And so you say even on assist control, after 15 minutes or so, they're able to cope with it. So how much ventilator to synchrony is there when someone's not sedated like that?
When they're not sedated, I guess it depends on the case. Like if their lungs are really bad and you need to have a really high rate to keep their pH balanced or something like that, then they might have a hard time with having a high respiratory rate, but chances are they're going to be breathing that fast on their own anyways because their body's telling them to.
Mm-hmm.
So even sometimes at the high rate, that's what their body's telling them to do. So we really don't see too much desynchrony, to be honest.
Yeah, that's a great point. I think that's a really common concern, or an understanding that sedation is to avoid ventilator synchrony. But when have you seen ventilator synchrony?
Honestly, I'm having a hard time thinking of somebody.
Isn't that great? What about when they're coming off of sedation? Like when we get patients from other places
that's about it, is that first 15 minutes when they're just kind of coming to terms with their situation
mm-hmm.
and trying to get used to it, and it just takes a few minutes.
Or they've been sedated for days, and then it takes longer to clear out. And
then they got those meds on board that kind of make your brain a little foggy, and they don't know what's going on. Mm-hmm. It takes them a little longer to clear.
I think from what I've seen in my experience is when we do sedation vacations or we start weaning off sedation, and suddenly we've got really anxious patients because they're delirious, because they're, mm-hmm. like you said, they don't know what's going on. Then we see the ventilator to synchrony, and there's assumption that it'll always be like that. But you suggest otherwise.
Yeah.
So when they're calm, cool, they're not fighting the ventilator, and we're able to get them up and walk them, what is it like from your perspective to walk a patient on the ventilator? And what's your role in that?
I was kind of, the first time I came to this hospital and they said, we're going to get up and go walk, and I was like, but they're on a ventilator. What are you talking about?
Right.
You have the wrong room or what? And so I was like, no, that's what we do. And I was like, okay. So how do you guys do this?
Mm-hmm.
So it was like, we just plugged in some tanks and hook them up to the vent, and away we go. Blew my mind the first time. I was like, okay. So, and I've seen almost every vent patient that's capable of walking eventually will get up and walk.
How soon after they're intubated?
Within a few hours. I mean, even just today, we had a patient that was intubated early this morning, came into the ER, morning rounds come up, and doctor writes in an order for physical therapy to come and evaluate, and we're walking at 10 a.m.
Just hop to it.
Yeah. Or if the patient is really just being intubated for like airway protection or something, and they wake up, and it's, we've walked people within 2-3 hours even.
What about when they're needing more ventilator support or on higher ventilator settings?
Sometimes that kind of feels a little iffy to me, honestly.
Mm-hmm.
Sometimes I don't always agree with it, but I'm not the doctor, so I do what I'm told. So we go up and we do it, and sure enough, they do just fine.
So sometimes you see those ventilator settings, and it's hard to imagine them being able to walk. Yeah.
So I mean, even with peeps of 16 to 20, it's like, what are we doing here? Are you trying to kill someone?
Have you ever seen anything bad happen? Any barotrauma?
Nope. Never.
Ever heard of it?
Nope. Never heard of it.
And how do you support them during that? So let's say someone has a PEEP of 16 on 80%. How do you get them ready to walk?
Well, since we only have one ventilator with the compressor, everybody pretty much walks on 100%.
Okay. That's great, though.
Which, gets them nice and oxygenated, so it's harder for them to get short of breath. It gives them all they can get for oxygen. Depending on their settings, if they're like already on CPAP, then I'll add, pressure support of 5, 10, 15, whatever they need. If they look like they're starting to increase their work of breathing, we can increase support just kind of on the fly as we're going, and try to make it so that they can use the rest of their body and not just get wiped out super quickly.
Right.
From respiratory standpoint.
And what do you do beforehand, before you walk them?
First thing you get in the room, basically just turn them up to 100% and get them hyperoxygenated while we, grab monitors and put the vent on the tanks and get everything ready, stand them up, get briefs on, do whatever we need to do. It gives them a few minutes to get all hyperoxygenated, and then away we go. And
what about after?
Afterwards, I generally try to put them back to their original FiO2 immediately. And most of the time they do okay with that. A few exceptions, when they have like some high settings, they might need a few more minutes. But generally they can come back to their previous settings pretty quickly. At most, I'd maybe give her an hour tops, and then get them back to their original settings. So it just depends on the patient. Sometimes they're okay immediately. Sometimes it takes them a little bit of time to come back.
And you customize it for their needs.
Yeah.
What about secretion mobility?
Anytime you get the body moving in different directions, gravity's going to pull sputum and phlegm from corners of the lungs and get it moving. So, whether they're up and walking, which helps, sure. Even just rolling them side to side doing bed care would get that moving as well, but you definitely see some while they're walking as well.
Do you find yourself suctioning a lot more out after a walk?
Yeah, suction them before we go walking, since you don't have the ability to do it while we're walking. But then when you get back, a lot of times you end up doing it again and getting more out. So
yeah, that's great.
Yeah, it definitely helps with some secretion mobilization.
How do patients tolerate it? The walking?
It's kind of funny. I feel like a lot of it is attitude, maybe. Like, patients just have a really hard time wanting to get up. And I mean, you can understand, you see all these lines in you and tubes and machines, and you're like, and why do I have to do this? Why can't I just lay in bed and get better? And so a lot of times our fantastically positive physical therapists will pep talk them for a few minutes, and basically we don't take no for an answer. We just keep pep talking them until they finally say, fine, we'll get up and walk. And they do it.
And are they coughing and gagging the whole time? Are they?
Yeah, some of them. Mm-hmm. So sometimes it looks like it is not fun.
Yeah.
So you just carry a rag and catch their spit.
But they do okay, and they take breaks when they need to.
Yeah, they always have a wheelchair behind them, so if they need to take a break and sit down, or if it's getting to be too much, they get dizzy, whatever, treat as much symptoms as you can on the fly.
Do you feel like it's safe to walk someone on the ventilator?
Yeah, I don't see, in and of itself, just walking them just because they're on a ventilator is fine. Like I say, sometimes those high settings feel a little iffy, or if they're hemodynamically unstable, it feels a little iffy. Like just yesterday, we have someone that has AFib, and so when he stands up, it triggers it, and his heart rate shoots from 80 to 180. And we had a physician come in and look at it. We printed it out, did an EKG while he was doing it, and determined, yeah, it's really high rate, but it's not going to cause him to have a heart attack. So let's keep going on with the mobility.
He stayed stable. He was like, not symptomatic. He was able to, continue to oxygenate.
He does get a little symptomatic, and so when he gets dizzy or something, we let him sit down and recover. And when he sits down, his heart rate does come down quickly. So,
and everyone's followed with a wheelchair, and there's always, that option to rest if it's needed. We're not just following everyone with a whip, right?
Yeah, right.
We do have some patients that are listening to music and they're kind of shaking and dancing, while they're walking. And then we have some people that can walk 5 feet at a time and need a break. And so every patient, every case is different. I never mean to make it sound like, people are just skipping through the halls with their ventilators, though some are pretty close.
Yeah.
But I think they do appreciate being able to take showers. So tell us your secret. That's what a lot of people want to know. How do you get a patient on a ventilator into the shower?
If we have time, we kind of need a low patient census, because then I got to stand there for 30 minutes. Or however long it takes them to the shower. But basically, I just go grab some extra corrugated tubing that's like 10, 15 feet long that I can take and just add onto the ventilator circuit. So you just got a little adapter and put it in line. So I also don't like to do that with people that are on really high PEEP.
Right.
So it's patient dependent as well, but and that's also not great for long term, but for 15-20 minutes it's okay. As soon as they come out of the shower, I take all that long tubing off. But I've never had an issue with it. So
what do you think that does for patients, or what do they look like afterward?
I couldn't imagine not taking a shower for, some of these people are in here for a month if they're
ARDS.
Really sick with ARDS or something like that. Yeah. And could you imagine not taking a shower for a month?
Oh no, it would drive me crazy. I feel like that's like a psychological necessity.
Yeah.
And if these people, they're awake, they know what's going on, and just when I see them rolling out in the wheelchairs, we walk them to the shower and they roll out, they just have a glow about them. Not just a wet shimmer, but they just, you can tell that they feel better. They feel more like themselves. Their morale is boosted. Yeah.
instead of a patient.
Yeah, that's a really good way to put it. I feel like a person, not just a patient. What does that mean to you to be able to provide that kind of quality of care and that kind of difference for a patient?
It's definitely more fulfilling and rewarding to take care of patients that you feel like you're kind of going an extra mile for. Whereas if they were just at any old regular hospital, they just say, sorry, we just do shower caps and rags.
Yeah, probably wouldn't cut it for me. But when someone's just comatose, there is no option.
Right. Then that doesn't happen.
Yeah. Well, what does it mean to you to know that 98% of your surviving patients go straight home? What role do you think you've played in that?
As a bedside care worker, we really, at least I don't ever hear of any statistics or anything like that. So whenever we do hear something like that, it kind of, what's the word? It makes it feel like you're doing something.
Like it's all for something.
Yeah, like it kind of comes together in the big picture is what it kind of feels like. So you come to work every day and it just sometimes feels like another day at work. But when you see the big picture and it's like all this work is paying off and you're seeing great results overall, it kind of drives the picture home that you're making a difference.
Yeah, and I think you and all of respiratory therapy makes a huge difference. I think you guys are one of the big heroes here in the ICU. The fact that hardly any of our patients have tracheostomies or go to long-term care facilities really comes down to you and physical therapy and the nurses going that extra mile, genuinely caring and getting people up and walking right away and throughout their critical illness. So thank you for all that you do, the big difference that you make, and for sharing your expertise and trade secrets with us.
No problem.
Thanks, Cash.
If you want to join in on the conversation, leave a voicemail at 801-784-0472